We'd like to invite Dr. Atanu Pal, Associate Professor, 𝐼PJMEA, to the stage. So Dr. Atanu Pal will give us a talk on sepsis post-transplant.
Oh, probably I'm on time. I had my OPD, so running directly from OPD. So, first of all, I express my gratitude towards this whole ISOT organizing team for giving me this opportunity to present here, to say something in front of you people. So, here I start with my talk, that is disease donor with sepsis. So the problem lies with the organ transplantation, the kidney transplantation or whatever. The problem is the particular organ. So there is a shortage of organ in all aspect. So in any way, if we can increase the amount of organ for the transplantation, that would be always best for the society, as well for the patient, as well for the family who is actually suffering. Now there are lots of challenges to get these donors out of all this. One of the commonest thing is the infection. And when the patient or the donor, particularly the disease donor who is having sepsis, whether to take it or not, that is the most important challenge or most important question. And it is seen that around 20% of the all donor pool are having sepsis, either detected pre-transplant or detected post-transplant. But we actually do continue the transplantation. Now, there are even bacteremia, which is most lethal. Also, those patients or the people are getting transplanted, or the organ getting transplanted. So, somehow or sometimes we might know that the patient is, the donor is suffering from sepsis, or sometimes we may not, and there lies the problem. So there are, it's okay. So there are some consideration where we actually take this kind of donor in transplant scenario, where the patient is not having any other options other than to take this. Number two, the availability of the other alternative process, or particularly the organs or the recipient's informed consent, that is the most important, where knowing each and everything, taking the risk is most important, and that should be discussed with the patient and the patient's relative, and so they should accept it or not. And the most important that happens is the transmission of particular infection from the donor to the recipient, and that might cause the endanger of the life, and so whether to continue or not. Now, whether the patient, that is the recipient, whether he develops the infection, whether it is a de novo infection or it is the donor who is giving this infection, it is again a big question, because most of the time it happens that the donor is from the one institute and the recipient is from other institute, and so the communication with this is very scanty time. It is very difficult to know what is actually the scenario in the donor. So their exact transmission rate identification or calculation is very difficult. Now coming to the changing paradigm. So what was the earlier concept? That is in 1970s, 1980s, 1990s, even with the Danovich or with the Morris, we had the evidence that the absolute contraindication for transplantation was the sepsis with the donor. Now, the scenario came into change in 1980s, or just like before that. The first case series that was published in 1980s, it is by Odenheimer et al., and they have shown that the 15 patients that the cadaveric donation, the kidney donation, they have performed, where the blood, the flushing fluid, the urine, or the wound, everywhere they got the Staphylococcus epidermidis. Now, whether this epidermidis, Staphylococcus epidermidis, was causative for the pathogenic for the sepsis or not, that was a very crucial question. But because the clinical data was not available for the particular donor scenario, but they have transplanted with this evidence that all the fluids are having this infection, and with the proper antibiotics what they have given, with that all the recipients were ultimately saved, and ultimately the successful transplantation was done. So this is one kind of scenario that is changed in 1980s. Next came into another very, very important picture in 1997, another study that is by this little group in Ireland. They have shown that with even sepsis, the donor died, but they have taken those organs for the transplantation successfully into the recipients. And with this, they have shown that even with a severe type of sepsis, with particularly say Staphylococcus epidermidis or Staphylococcus aureus, even with the organ, they can even transplant to the recipient, and that can be saved, and that can ultimately a very good pathway to have more number of organs to be transplanted in the recipients. And next comes the another scenario where this more or less in 2001, that is I'm talking about the year 1980s, 1990s, 2000, 2001, 4, like that. In 2001, another paper came into the scenario is that they have ultimately identified that we can transfer or transplant the organs where the donors are having severe of sepsis with some kind of consideration in terms of identification of the bacteria, whether it is a pathogenic virulent organism or it is a more less virulent organism, and where they have found that if it is a gram-positive virulent organism like Staphylococcus aureus, then you should not go for the transplantation. But where the Staphylococcus epidermidis is there, which is less virulent organism, you can transplant. Again, there are some other organisms where you can transplant this organ into the recipient. Again, if the fungus is there, then don't go for transplantation. Like that, they have a review and there a publication. Next comes the another very important registry, that is the Spanish registry in 2008. They have shown that the non-infected versus infected donor, if the organ are taken, then there is at least no such difference in the outcome, both as short term as well as long term. So this is another very important observation they have shown. Now, going to the real life scenario, it is very easy to say that if the patient is suffering or the donor is suffering from sepsis, just straight away you can go for transplantation. But what actually is the scenario? So this is the real life case that I have put here. It is in 2004, they have shown that one patient, means a child who was actually a Down syndrome patient, he was having some heart defect and going for some revision of the surgery, ultimately developed pericarditis along with severe sepsis, bacteremia, etc. And the blood grown, it is a gram-positive cocci. Septic thromboemboli and the microabscess in everywhere, and mixed bacterial and the fungal tracheobronchitis. With this, the kidney and liver, they are accepted with the proper consent from the recipient and the recipient's family. Now, the first recipient, it is a 41-year-old woman with ESRD. What they have done a steroid-free regimen with tacrolimus, mycophenolate and the daclizumab, and the cloxacillin that was continued because it was shown that this gram-positive organism was sensitive to cloxacillin. So pre-operative cloxacillin plus post-operative cloxacillin with steroid-free regimen they have continued, and ultimately the patient survived, and her creatinine was 1.54 milligram per DL at 1 year. The second recipient, again, kidney transplantation in a 23-year-old woman with chronic glomerulonephritis. The same regimen they have used, that is steroid-free regimen, and she had satisfactory graft function, and she was treated for a total of 4 weeks of cloxacillin. That is another very important at the time. The cloxacillin was sensitive. I am talking about year 2001 to 2004. Now, the patient readmitted 8 weeks after finishing this cloxacillin for evidence of CMV, not with the gram-positive organism, but for another infection, that is CMV, that might occur, and ultimately treated with the ganciclovir. And at the end of 1 year, Again, she was maintaining with a creatinine of 1.74 milligram per DL with a stable renal function. The third recipient was a liver recipient. And there, it's a 10-month-old boy had a failed this Kasai surgery and ultimately got this liver, and ultimately the patient was doing well. But as they use the low-dose tacrolimus with steroid regimen, ultimately the patient developed acute rejection in postoperative day 10, and that was managed very well with the steroid and hiking of the immune suppression and the rapamycin for 6 weeks now onwards. And after that, the patient becomes stable and maintaining a good liver function at the end of 1 year. So, nearly 2 years after transplantation, it was shown that all 3 recipients continue to do well with no known sequelae of having received organs from Staphylococcus aureus sepsis donor. So, this is very important observation of how they tackle, how they monitor, and how it was continued. This is a real life scenario where we can have a good example. Now coming to a recent article, that is a randomized, I would not say it's a randomized trial, but it is a retrospective, well-organized observational study. It is a Korean study. They have published, at least in this scenario where data is very much lacking, 10 years data of having infected versus non-infected donor, and they summarized it very well that only 1.2% transmission occurs from donor, infected donor to recipient. And if it is bacteria, and if it is a fungus, then the chance of transmission is around 16.7%. So this is not very high. And you can see here the profile of the non-infected donor and the infected donor, it is more or less matched. There is no such significant difference between the infected and the non-infected donor in terms of each and every thing like epidemiological as well as the HLA matching and others. And this is the 1 year graft survival as well as the 1 year patient survival, and there was no such difference in these two donor. And if you see the long-term outcome in infected donor as well as a non-infected donor, the graft function was stable and not significantly different in both the scenario. And the allograft survival as well as the patient survival were more or less same in these two pictures. So this is another very important finding that we got in this particular paper. Now, what is our scenario? We had our experience of disease donor since 2016. This is the first disease donation that the kidney transplantation that we did, and there we have found that the patient, when he was transplanted, ultimately the graft was doing well for the next 2 weeks, but after 2 weeks the patient started developing recurrent pleural effusion. We had done each and everything with collaboration from the CTVS, from the chest department, from the cardiology, but ultimately it was found that the patient was grown actually the candida, and the candida is everywhere, even in kidney, and ultimately the graft nephrectomy was done to save the patient. And the recent experience in 2023, the last liver kidney combined transplantation that we did first time in Calcutta, with this we have seen that a 28-year-old male with CKD stage 5 with HDV age of 10 years with chronic liver disease CTPB, the patient was transplanted, and ultimately patient was doing well for the next 24 hours, but suddenly patient developed shock, a severe shock, severe septic shock, and ultimately patient succumbed to death within 48 hours. And another patient who was a kidney recipient,
to interrupt,
he
requesting
also,
you to conclude,
yes,
sir.
just 1 or 2 slides. The patient also succumbed to death within 48 hours of transplantation, though the patient was doing very well. The urine output was around 1000 ml per hour for the first 24 hours. So ultimately, we could found that it is the Acinetobacter baumannii that was grown 48 hours after transplantation. That report came later, and ultimately that was the cause, and that also grown in the recipients, in both the recipients. The newer challenge that we have, it is the MDR organism. That in current scenario, it is the nature's summary or the review where they have shown very nicely that how to tackle this MDR organism in current scenario, like crab, like CRKP, like CRE, etc. And where you have to identify or screen the patient, that the donor, very thoroughly so that the prolonged stay in the hospital or the critical care unit, critical care illness requiring vasopressor support or the ventilatory support or the cardiopulmonary resuscitation, they are prone to develop this fatal organism. And for this particular group of people, you need to screen and you need to either treat these donors before transplantation, and after you are confident, then you can transplant this particular donor to the recipient. And for that recipient, you need to continue the antibiotics, the same antibiotics for 2 weeks to 6 weeks time period. So the take home message, the disease donor with the sepsis, not a contraindication for transplantation. The rigorous screening for specific organism with newer technique like multiplex PCR is required. Sepsis with gram-positive virulent organism, MDR bacteria, fungus, better to avoid, at least till today, and or it may be individualized in case-to-case basis. Perioperative broad-spectrum antibiotics may improve outcome along with the modification of the immune suppression, but it needs more studies. Thank you. Thank you for patient here.
Thank you, Dr. Pal, for your excellent presentation. I think we are short of time, so we can skip questions. Thank you very much.